My name is Hina Akburli. I'm a graduate student at University of Houston in the F&P program, and today we'll be talking about a specific kind of renal injury in this case study called acute tubular necrosis.
The HPI includes the patient's chief complaint and a brief overview of the patient. In this case, the chief complaint is weakness and dizziness. The information we have on the patient is that he is a 78-year-old Asian female who was admitted to the hospital with an acute GI bleed with bright red blood per rectum that started 1 hour before admission. Upon admission, he is pale and sweaty. The bright red blood indicates a lower GI bleed. If the blood was dark red or black, that would indicate that there was mixture with the gastric acid. Now, the pale and sweaty symptoms may be indication of losing blood and possibly going into hypovolemic shock. When assessing the patient's medical history, three main aspects should be assessed: present medical history, social history, and family history. In this case study, the patient has had hypertension for 25 years and congestive heart failure for 8 years. As we will see in the next slide, the patient is taking medications to maintain these illnesses from worsening, but his physical assessment and further evaluation of the patient may point to signs and symptoms of these illnesses. When asked about social history, it is important to assess the patient's occupational status. Doing so will help you further evaluate the stress level of the patient. And sometimes stress levels can be a causal factor to some illnesses, although that is not the case in this scenario. Although the patient abstains from tobacco use, the use of cigarette smoking would be an important factor to include as well. Typically, in a family history, you want to go back at least 3 generations, but this short family history tells us that both parents suffered from comorbidities. Now, before we dive into the patient's medications, it is very important whether the patient is young or old to always assess for any medication allergies. Fortunately, in this case, the patient does not have any known drug allergies. Now, right off the bat, you may recognize these medications. Digoxin is given to the patient's due to the patient's history of CHF. This medication helps lower the patient's heart rate, thereby allowing the chambers more time to fill up and as a result increases cardiac output. One of the most common signs of CHF is the retention of fluid. Furosemide, or Lasix as you may know it as, will help flush out the extra fluids in the body. One of the key things to remember with diuretics is the depletion of electrolytes. Monitor the patient's electrolytes because hypokalemia, hypomagnesemia, and hypercalcemia can place the patient at a greater risk for digoxin toxicity. So that's how those two medications can go hand in hand. Enalapril is an ACE inhibitor that helps lower the patient's blood pressure. Famotidine is an H2 blocker that is given to lower the production of stomach acid to help with the relief of gastric reflux. Review of systems is very important. It essentially helps you paint the picture and further assists you in your diagnosis and clinical judgment. You would typically include the pertinent negatives and pertinent positives of subjective data. As you can see, the patient was so ill that the patient could not appropriately respond to the questions. On the bright side, we have the patient in front of us and our amazing set of assessment skills to help us paint the picture, so to speak, by obtaining objective data. Glancing at the physical assessment, there are several signs that indicate low blood volume, such as pale appearance, conjunctiva are pale, tongue is dry, low blood pressure, and elevated heart rate is an indication of hypovolemic shock. The faint S4 cardiac sounds is another indication of low blood pressure or low cardiac output. Assessment of the abdomen seems otherwise normal, but our review of systems would have given us more details if the patient was experiencing any abdominal pain. The bright red blood per rectum is a red flag that requires further assessment. As far as diagnostic tests, you can see that in the red lab values are all over the place. So, but it should not come to a surprise that the hemoglobin and hematocrit levels are low, and this is due to the rectal bleeding. However, due to the hypovolemia, the BUN has elevated and is highly concentrated. This indicates that the patient is severely dehydrated. Although electrolytes appear within normal range, that can also change depending on at what point of the during the patient's admission these lab values were taken. The creatinine levels are exceptionally high, which gives indicator to possible acute renal failure. The urinalysis at the time showed heme granulocytes, proteinuria, and presence of red blood cells, which are diagnostic for glomerulonephritis. White blood cells are seen also in the presence of infections. The patient was given multiple units of blood and was given aggressive IV hydration. Once the patient's blood pressure was stabilized, he underwent a colonoscopy, which indicated several diverticula in the ascending and descending colon. This was presumed to be the possible source of bleeding. Chest x-ray showed CHF. So the patient already had CHF, now it seems like it's coming back. Based on the information acquired through the HPI, the physical assessment, and diagnostic tests, we can list some differential diagnosis. Now, differential diagnosis is the process of distinguishing the possibility of one disease versus another based on similar signs, symptoms, and clinical features. Acute tubular necrosis is our working diagnosis and may have occurred due to a blood transfusion reaction, hypotension, or shock. Another possible diagnosis would be glomerulonephritis due to the sudden onset of hematuria and proteinuria, along with the elevated BUN and creatinine levels. The third differential diagnosis would be nephrotic syndrome due to the kidneys losing its ability to filter blood because of the damaged glomeruli, and therefore waste products are building up quickly in the patient's system. So what exactly is acute tubular necrosis, or ATN? It's defined as tubal cell damage and cell death that usually result from an acute ischemic or toxic event. There are three major causes of acute tubular necrosis. That's renal ischemia, sepsis, and nephrotoxins. For the sake of this case study, we will focus on renal ischemia. All causes of severe prerenal disease, particularly if accompanied by hypotension, surgery, or sepsis, can cause ischemic, also can cause post-ischemic, also called ischemic, acute tubular necrosis. Now, ATN is an unusual complication of heart failure. However, in this case study, you can see that the patient is seen with systemic hypotension and volume depletion, as well as congestive heart failure that has reappeared. So what is our plan? After diagnosing the patient with ATN, he was administered a renal dose of dopamine and furosemide IV. It's important to consider the renal dose because of the acute renal injury. You don't want to give a normal dose. You want to give a dose that's adjusted based on his renal function and his GFR. Despite the efforts of IV hydration, however, the patient continued to have poor urine output and became fluid overloaded. This gave indication to place the patient on continuous veno-venous hemodiafiltration, or CVVHD, for 3 days. Now, it's important to monitor the patient's intake and output after the use of this device because the patient will have copious amounts of urine output. This device, essentially what it does is it's like an external kidney. If since the patient's kidneys were not functioning, this device will help filter out toxins and basically do the functions of a kidney. So it's important that you monitor this patient's I's and O's because the patient will have copious amounts of urine output after being on this machine. The patient will continue his previous medications, and that was digoxin, furosemide, enalapril, and famotidine. One thing to remember about enalapril is, as you know, it's an ACE inhibitor, and ACE inhibitors will in fact help protect the kidneys as well. You'll see a lot of diabetics taking ACE inhibitors, and they'll even say, oh, I'm not taking this because I have a blood pressure problem. I'm taking this so I can protect my kidneys, and that's the case. Goals in education. So this is very important upon admission to the hospital as well as discharge. Whenever the patient is admitted to the hospital, your plan of discharge starts right then. Your education is ongoing from the moment that that patient has stepped into the hospital. So you want to limit his sodium intake to prevent further fluid retention because, as you may have learned, where salt goes, water follows. So also be wary with salt substitutes because they are high in potassium and you don't want the patient to be retaining too much potassium. Also advise the patient to follow a low protein diet. Since we will be restarting the outpatient medications, it is important that the patient remains compliant to the medication regimen since most of his medications affect his cardiac and renal function. These are a list of some of the medications that can increase his risk of nephrotoxicity. So you want to educate the patient on avoiding these medications, especially NSAIDs, since they are readily available for him over the counter. And most of the other medications have to be prescribed by a provider. Involve his wife in the plan of care to allow better adherence to his medication and his diet. If necessary, use a translator when providing discharge education to the patient and/or family. So continuity of care, what parameters should be monitored once the patient has been discharged? What should the patient be looking out for? So you want to emphasize on the importance of monitoring his intake and output. I've been emphasizing on this throughout the case study about I's and O's because we are talking about renal function, and one of the most simple ways you can, as a nurse, can evaluate renal function um, on the floors or even at home is by monitoring a person's I's and O's. And you want to educate the patient to notify the provider when he notices a trend in low urine output, which will typically be less than 30 cc's per hour. Now, in a perfect world, as far as blood pressures go, I would like it if the patient could check his blood pressures twice a day, once in the morning and then another time in the middle of the day. However, in reality, you'll be lucky if they remember it to check it even once. So have the patient log the blood pressure readings and bring it to the clinic to the next follow-up appointment and look over that and see what the trend is. See if he's trending too low or trending too high. In a patient with renal disease, the goal blood pressure would be less than 130/80. But you also want to consider the age and the weight of the patient as well. So when would we see this patient again? I would like to follow up with the patient in 1 month to see if the patient has been compliant with his medications, diet, and meeting his goals. In addition, I'd like to get another follow-up on his labs. The CBC with differential, the BMP, which will include all of his electrolytes. You'll notice that I've added an A1C to be checked because of his family history of type 2 diabetes. And then also to check his urinalysis again. Typically since we're also going to be checking for proteins, I would want the UA to be a 24-hour collection. I would then have him come back 6 months later for another follow-up, and then every 6 months again after that. Thank you for tuning in, and I hope you learned a lot about acute tubular necrosis through this case study. Thank you very much.